Dr. Parker Fillmore, how are you, sir?
I'm doing great. How are you?
I am doing well. Thank you for coming today. You and I got connected months ago. We've been trying to get things scheduled, busy for both of us over the summer, but man, we made it. Here's to you, sir.
Absolutely.
Listen, you came on my radar because there was a problem in the Treasure Valley, problem with medical professionals and professionals in general, but medical professionals is your field, with non-competition clauses where, people come into the area, they either come into the area or they're already in the area and they just gain employment through, one organization or another. And the problem is then that organization, if they have a non-competition clause, they have restrictions if you leave the organization or if the organization shuts down the branch that you happen to be in, depending on how the legalese are written. But you can end up in a situation where we have a very, very needed professional, let's say a medical professional, that because of a contract they signed, some time ago, they are no longer working for that organization, no longer offering that service to the community, but they're also hamstrung from offering that same service in the same area with another organization. And you had a bad experience with that. And again, for people that want to dive into what that was, they can go read the news and whatnot. But this leads to a broader question about how do we solve the problem? Like if we had an abundance of medical professionals, this wouldn't be that big of a deal. If it was like we had, trauma surgeons and trauma care doctors and emergencies raining from the sky, it's like, okay.
Right.
But we don't.
We don't.
Why don't we have more medical professionals here?
It's complicated. It's complicated, but you have a couple of issues here. Number one, it's getting better. Like if you're speaking about Idaho and you're speaking about Treasure Valley, as we all know, everyone wants to be here now, right? And so what's the problem? Well, the problem becomes that it's not that easy to start a practice, right? It's not that easy to come into a new community and say, I'm going to take this risk on my profession, right? My career. I want to make sure that it's the right fit, right? I want to make sure this is going to work because it's really disruptive to try to restart your professional career as a medical professional again, right? So you kind of, and a community would like that, would like the doctor who comes to the community to be there for the long haul, that continuity. That's something that's desirable in the medical community.
If I may, to your point, my dad, as you're saying this, my dad experienced this exact thing. I was born when he was in medical school, and he became like a real established doctor by the time I think I was like 10, and then he moved to Alaska to Anchorage when I was 15, and he had this established practice here or back in the former state, and then he goes to Anchorage and has to restart and tries to open a private practice. And it took him, he got hammered. And then he was a general surgeon. Then he really found bariatric surgery as this niche that needed to be filled, like hyper specialized. And he was able to really build a practice around that. But he was he had his hand fellowship, he was general surgeon, and he was just dying to get things rolling. And it's really hard moving somewhere, at least from what I've seen. It's really hard moving somewhere and just, hey, I'll hang out a shingle and like all of these patients will fall from the sky.
Yeah. And so, in Treasure Valley, it's difficult as well because if you're a physician or a healthcare worker who needs to be attached to a hospital because of your profession, like for me, as my own example, I'm an emergency surgeon, which means that I take care of people who have either traumatic emergency or a surgical emergency. This is not something you schedule an appointment for. This is not something that you come and we work up the problem when we schedule a surgery down the line. You need help and you need it right now, right? And so I have to be attached to a hospital. I can't drop what I'm doing, drive 30 minutes, I'm at the hospital. And
where the traumatized individual comes instantly. They're like, get this person here right now. We got to go.
Right, exactly. And so in this community, you essentially have like two players, right? You have the two main hospital systems, St. Louis and St. Alphonsus. And so, you go where there's a job. And if there's a non-compete attached to that, that essentially means that if you do not work for us, you do not work here. right? And so it's you work for us or you work for nobody, which is a little bit of a challenge because, again, you make these choices, you make these sacrifices, these commitments, these investments in the community, and then if it's not working out, if the situation isn't right, you're out. You have to move somewhere else. But in my own particular case, I decided I wanted to have a career in Idaho because I saw some really unique needs that Idaho has, and it needs some development in terms of systems. And so in around 2012, the state really started to say, hey, we need to organize trauma care. We can't just have, a bunch of hospitals just doing their own thing. It needs to be coordinated. We need to make sure that we get the patients to the right hospital at the right time to take care of them. And so it was in its infancy, and I have a background in public health, and this is a great place to really get to work and see if we can improve access and quality of trauma care. Because as many people don't know, trauma is the number one cause of death for the productive age group of men and women, right? So accidental injuries, and now, unfortunately, accidental injuries from overdose is another big part of it. And so if we're not focusing on this age group and we're not focusing on this particular problem, they're not going to live long enough to have the heart disease, the lung disease, right? We're going to destroy our base that actually helps build communities, that actually is that produce in the community. And so it's a big problem that we need to get right. And it requires not just a single shop doing it on their own. It requires a lot of coordination, making sure. Yeah, go ahead.
No, I'm sorry.
I say making sure that it's not just the big cities that have trauma care, access to trauma care, but over 30% of Idaho's rural. What about these guys? What's their access to trauma care? And it's not great because of the resources. In fact, if you look at, if you live in a rural area, your chances of dying from an injury from trauma is like 50% greater than if you lived in the city. That's a huge change.
Okay, so when you talk about trauma for somebody like my age, like I'm 43, when you talk about it's like, hey, look, accidental trauma for you is going to be the leading cause of death. My heart is pretty good. Like my health is general health is good. So like what do we like an ATV accident?
ATV, that's a great one for the state. ATV accidents are a huge issue. Even just being out on your horse, right? Getting bucked off your horse. We love recreation in the state. It's one of the things that makes it so great to live in this state. But accidents happen. And if that happens to you in a remote area, you're in trouble. You're in trouble. And that's why you hear a lot of talk about, the fact that we do have a little bit of a crisis in access to care. Emergency service is not it's not designated as a critical need. And so it doesn't get a lot of funding and support at the state level. And so it's mostly volunteer in these areas. And so you just hope that, someone can get to you soon enough and that you can get to a hospital that can take care of you. So.
And you're talking about the problem in rural areas where they don't have professional ambulance services, where they have like volunteers.
Yes.
Like, hey, Jim fell over at, City of Rocks. Like, you got to go get Jim. And then it's like, oh, okay, like, hang on, like, put down the jump in the van. I have a friend who volunteers for his community as an ambulance driver on like Saturday nights. Yeah. And again, like he's
without
not even far
these guys,
away. He's not even far. He's like 45 minutes away. Yeah. They don't have a professional service up there. So if somebody has a heart attack, it's like, okay, somebody's got to go get that guy, get him on a stretcher, get him in the ambulance, drive his ass to the hospital. Like this is it, right?
Yeah. So you want to be able to have access to stabilizing trauma care in the state, and so we've actually done a great job. There's the time-sensitive emergency council. In the state, and it deals with not just trauma but also stroke and STEMI as well. These are the medical conditions. If you don't get care just as quickly as you can, you're going to have a bad outcome, including death. Right. And so this
or well, I don't know if I should say or worse, but substantial debilitation, where it's like, okay, you didn't die, but you never recovered your whole left side.
Correct. Correct. And you're in a dependent situation, and your medical needs are pretty great, and you become a consumer right now instead of a producer, right? For your community. And so it's one of those deals, like, getting back to the idea of the non-competes, is it's just one more example of policies that drive people out of the community who are already here and who want to be a part of the medical community. It just doesn't make a lot of sense. And if we're talking about, hey, there's a healthcare worker shortage, this seems like a pretty simple, fix to at least allow people who want to be here to stay here and practice.
May I ask you something? I've never had a job, so I don't know what the motivations are.
Can't believe that.
Yeah. Like, from the age of 22, I graduate, I started tutoring privately.
Yeah.
Like, I literally got a referral to tutoring from my rowing coach's wife. She worked at this like ritzy private school, and she's like, yeah, I got this 5th grader who needs math tutoring. I was like, cool, man, whatever. Like, put on my dumb little, polo shirt and khakis that don't fit me right. And like, all of a sudden, I got a lot of energy and I love teaching. So, like the 5th grader loved me. And then almost immediately I got into SAT prep, and that's all I did until the day I moved here. Then I moved here and I started a podcast. Like, no, I didn't apply to do this, so like, I literally don't know what resumes look like. Right. I don't know how to fill one out.
Lucky you are lucky.
Yeah. Well, maybe, but, there's a lot of risk involved there. But my broader question is, look, when you're applying, and you recognize, you're like, okay, I want to go to this area. Okay, because I presume it was like the area first. It's like, hey, Idaho has these opportunities, and Treasure Valley in Idaho seems like a good place to be. Awesome. And whatever the decision was, fine. And then you're like, okay, who has the job? Like, because I need to get a foothold. When you're contemplating applying for a job and you see a non-competition, what is that thought process? What's the motivation behind agreeing to it? Like, how does that all work out? Well, is it kind of like, I know 50% of marriages don't work, but I'm the one that's going to work?
No, and I mean, in my own case, I saw that, and I could see that, this could potentially be a major problem. But and at the time, there really was only, one hospital for me to work at, when I came here. And so it was, well, I'm just going to take a chance. I'm going to take a chance that this is going to work out, because one of the things that I saw as a barrier to improving trauma care in the state was, you need a lead. You need a leader, right? Who's going to take on that mantra of like, I am going to be the champion of trauma for the state. Usually it's a university hospital, right? That's usually how it works in other states. There's a university hospital that's like, hey, you know what? We're going to take the responsibility on. That means that it's not just about billing and taking care of patients for money. We're going to be a leader and do the things that don't make money: education, research, training, those kind of things that don't necessarily make you money, but they need to be done, right? And so you need one of those in every, state trauma system. And I thought, this is the one I'm going to align with. I think this one has the best shot of being that leader, right? And so that was really what went into that decision. I tried to get it out of my contract from the very beginning. I said, this is a problem. But you know what? Good faith, I'm going to go forward, and we're going to give it a go.
So with that, and again, people can do whatever they want, right? People can agree, they cannot agree. Organizations and hospital systems can require whatever they want in their contract. Right. Like the free market will work eventually. Sure. But recognizing that, like, what are the things that can be done then to start addressing, with whatever the environment is, start addressing attracting more people here? Is it organizing more? Well, what is it? Because this is our big problem, right? You have a lack of people. Like, you look at OBGYNs. Okay. Gal was telling me, Tony Lawson from the Hospital Association, she was on, and she was telling me about this rural hospital that had just, and again, like the majority of Idaho is like an OBGYN desert. They I think it's like 7 counties have all the OBGYNs, or like 95% of them. So the other counties don't have them. And she was at a hospital, and the director of the hospital was like, oh my gosh, we just got our OBGYN. Like, we've been trying for years. He's in there delivering right now. Like, he was super excited. He's like, but I have to get another one, because if I don't, that guy's not going to last a year. Yeah. Right. So we have this problem where it's, in some areas, we're literally starting from the ground up, and there's this very delicate beginning phase where you've done the heavy lift to attract someone, but the clock is ticking, man. Yeah, it's like Marissa Tomei, the clock is ticking like this. And if you don't get somebody to support them, you're going to lose that person too.
That's right. That's right. And it's multifactorial, because, speaking of just that individual, right, you're going to kill him, right?
Right.
He can't be on every day, 24 hours a day. You need critical mass, right? But if you're losing them as quickly as you're putting them in, you're not getting anywhere.
Right. So it's like you can't get out of the atmosphere. You can't.
Exactly. And so it just becomes a very difficult environment to work in. And a lot of it comes down to, I think the way healthcare has shifted, it's more of a business model than a healthcare model.
Explain that to me.
Well, what I mean by that is that I'm biased in that I think that the best healthcare model is a public health model, and that means that you're actually looking at your community's needs. You're not looking at, hey, this is a service line we can start and it's a revenue stream. You're actually truly looking at, okay, what does this community need? So in the case of OB-GYN, right, we need OB-GYN. So and this community needs it. We're going to do everything we can to make sure that we provide that. It might be a money loser.
So you have to have like loss leaders, but you have it because it's the value add.
Yeah. Yeah. And, and that's what, why we have nonprofit hospitals, because they're able to, I think, navigate that better. But in terms of, making sure you have the community's needs filled, that's got to be your number one priority. And that takes coordination, and it takes, a lot of collaboration between health systems. Healthcare should not be competitive. We shouldn't be talking about market share in any hospital boardroom, right? That is a no-no. And I think the majority of healthcare workers and physicians, I think we're apolitical, right? We're not, one side of the aisle or other. We just want to take care of our patients and provide the best care for our patients. And what we end up finding a lot of time in our day-to-day jobs is we're not able to do that. We're being led one direction or another, whether it's from decisions of staffing, right? So you have staffing issues where they run lean, right? That's a business idea, right? We're going to run lean so we can really keep that margin down.
That's not a health decision, that business.
It's a business decision, and so that's why you have long lines in the ER, right? Waiting to get into the hospital. It's not necessarily because there's no beds in the hospital; it's just no staffing, right? And so you may have a queue in the ER. You might spend a day in the ER waiting for a bed in the hospital. It's not because there's not an empty bed; there's no nurse to take care of the patient, right?
Right. Yeah. I had Brad Turpin from the Emmett Hospital System in. It was, a long time ago. I think a year and a half ago. And they had shut down their labor and delivery. And he's the CEO of the Emmett Hospital, and came in and explained, because somebody had told me, hey, look, the legislation we had, it's so terrible. We lost, Emmett lost labor and delivery. And I got a hold of Brad and asked him if he would come in. And he said, yeah, like, I'm happy to come in, happy to talk about this, but it's really not, it perhaps is part of the legislation. Yeah. But it's also all of these other things. And I was like, God, tell me about it. So he comes in and explains, says, look, if you got a labor and delivery, that's great. And you better be on it. You better be able to deliver babies, and you better be able to deliver them well, 24 hours a day, 7 days a week, and do it well. It's not a half measure thing. Yeah. which means you have to have all the supporting mechanisms in place in the event that it doesn't go the absolute best way. It was like, you got to have an operating, system 100% of the time. Cause like if you got to do an emergency C-section or things like that, you got to have all of these supplemental things. And he said, it became too costly. And then, staffing, he was like, you have staffing, you have midwives, you have nurses problems. We can't get nurses in. So then we're doing locum nurses that are, temporary traveling nurses, and those are a dump truck of money. And so you have all these things. So they had to shut down labor and delivery. And again, I'm not saying Brad made the wrong call, that his hospital system has to stay solvent. But to your point, he had to shut it down, not because he's like, hey, there's nobody in this community that's going to deliver a baby. He had to shut it down because he said, look, effectively, there aren't enough people in this community having a baby. And again, he has to make a business decision on how to best manage the cost of everything and whether or not it's a appropriate ROI.
Yeah, that's a community health assessment.
Right.
That's what just happened there. He's like, there aren't enough deliveries. Let's figure out how we can make sure these deliveries happen safely, elsewhere.
Right.
And so that's kind of a coordination, collaboration, effort as well.
Yeah. And when you talk about our medical systems being driven by business decisions and not health decisions, to what degree do you see that same parallel with the politics around medicine? Because medicine has become politicized like crazy. And again, we all know, like women's health has become a big thing, right? Like we have legal or state policies and laws that are in place that have the effect of driving down the population of OBGYNs in the state. Like that's just kind of fact by this point, and how people navigate it is up to them. Right. And, like I don't know, like Idaho's going to figure this out, I'm sure. But again, like what are do you see other political things that are detracting from the medical first focus?
Yeah, and I think we see this. I think recently we've seen it a little bit. Obviously around COVID, right? Hot button, issue. And,
Sure.
the last legislative sessions where we saw things like, you can now get ivermectin over the counter, right? These are ideologies. They're pet projects. They're not really moving the needle in healthcare. Freedom to, not get the vaccine. It's always been, your freedom. And so when we start focusing and shifting attention to politically charged health issues, what ends up happening is the important issues are forgotten. And, we talked a little bit about this when we talked about kind of trauma. We talk about, the opioid, crisis. We talk about, children's health right now is, I'm worried about it. I've got, young kids still looking at the struggles that they're going through with, integrating technology in a healthy way in their lives.
Right.
All of these things, they're hugely important issues, but they don't get a lot of attention because they're hard. They're hard problems to fix. Whereas, focusing on, whether or not you must have a vaccine to go to work is so much easier.
Can I ask you about that? That was a piece of legislation that did in fact pass, that you couldn't, if you're a business, you could not restrict somebody based on their vaccination or health status. And that applied to medical practitioners as well, right? So like if I'm a pediatrician, say I have a private practice, I'm a pediatrician, and let's say I'm really into vaccines. I'm like, hey man, I as a doctor, I think this is really important. And honestly, if you're a parent and you're coming in and you don't believe in vaccines at all, you and I we're just not going to jive, right? Yeah. Like, because what the reference that I'm coming from, or the ground I'm standing on, is not the same foundation and ground you're standing on. So if I give you a recommendation, you probably won't listen to it anyway. So just for me, I'm just going to decide like, hey man, if you're not into vaccines, then, I would like to not have you as a patient. And guess what? That's probably works for you anyway, because you probably wouldn't like me, right? Because like, there's no reason you're going to want to come and have me be your doctor if we have different references based on contemporary medical decisions, right? That got the capacity to make that decision got removed, right? Now doctors cannot take that into account when they're considering whether or not they should have a patient in their practice.
Right. Yeah. So,
And that's not a medical decision. That's a philosophical or ideological decision. Again, rules around healthcare not being determined by health and medicine.
and even just applying the label of science, right? And, you know, what is science? And, you know, opinions, everyone's entitled to their own opinion. I would never, you know, take anyone's right to have an opinion.
Sure.
But when you try to substitute opinion for a scientific-based recommendation, there's a different weight that you can assign to each of those. And I think there's far too much medical opinion right now and not enough science. And you say, well, it's corrupt, right? The pharmaceutical industry is, you know, fudging the numbers. And you have a few bad actors that's true. But we have a serious trust issue right now in terms of who are we trusting for our medical information? Are we trusting you know, the sound bites and the politicians, or are we going to trust the scientists who can actually lay it out? Like, these are the numbers. This is the number of patients treated. This is the number of patients who had complications. This is the number of patients who, you know, had a shortened length of illness or a cure, right?
Right.
Just lay it out. Like, these are the numbers, and have someone really explain this is the math behind it, right?
Right.
It's just so much harder to get that across because it takes a little bit of time. You gotta sit down for a minute. It's not a 30-second exercise. It's probably a 5-minute exercise to understand, you know, the great things that have come from, you know, scientific advancement of medicine. You know, when we talk about make America healthy again, right? We have to say, okay, when was it healthy? You know, what are we trying to get back to? Do we think we're going to be healthier if we go back in time? And when would that be? We live in a different world. We just need to make America healthy for everyone now.
Let me ask you something. This is one that it really, it was like, I don't know how to reconcile this. I have an aunt. Not, she hasn't passed. I have an aunt.
She's listening. So
she's definitely not listening, but she had a kid, my cousin, and she had a lot of alternative views, like a lot. Yeah. And one of them was, I don't think that my son will ever get sunburned if I give him the right diet. And I was like, interesting. And she was like, and sunscreen kills you. I was like, also interesting. Now, mind you, I'm like 23 when I'm hearing this. I'm like, she did it again. Oh my, like, you never know what's coming out of her mouth. This is great, right? Yeah. And then I come to find out, like a decade and a half later, like, oh, no, banana boats are really bad for you. I'm like, wait, what? Like, do you remember in like 2023, when I was 23, in like 2005, 2006, there was that, it was like that slam poetry thing where the guy's like, use sunscreen, the long-term benefits of sunscreen. And they put like, a beat behind it. And he's like, dance, even if it's by yourself in your room. And it's like, use your body. It's like, it's like real feel good thing. Right. But it was all about like, it was this commencement speech, right, at a graduation. And the guy, his primary thing was like, put sunscreen on. Right. Then we come to find out it's like, that's really bad for you. Now, it may have the intended effect of preventing some manner of cancer, but it may promote or have a higher probability of having other cancer, right? So
yeah. So
how do we, like, first off, banana boat, you a fan or not?
I've never used it. So.
Do you use sunscreen in general?
Yeah.
Okay, what kind of sunscreen?
Not enough.
So you're a sunscreen guy.
Yeah, I am, because UV radiation is real.
Yeah.
It's real. Like, we can measure it, and we can measure the effect it has. We have population-based studies that show, you know, fair-skinned people like myself were predisposed because of the pigment in our skin to get skin cancers, right? And so anything I can do to prevent UV radiation from damaging my DNA, that's going to lower my risk of cancer.
Is it anything you can do, or is it something that minimizes this more than it raises a risk over here. Because you're not going to use the worst sunscreen, right?
Exactly.
You're not going to use sunscreen with really bad stuff that gets through your dermis, right? You're going to use sunscreen that minimizes your risk of skin damage, but also doesn't add additional risk.
Yeah, and that's a really good point, because this is all about risk mitigation. Right?
Yes.
It can't be zero, but I'm looking for the least worst.
Yes.
Right?
Yes.
What's the least worst? And melanoma is kind of a bad one. Right?
That's a bad one.
It's a bad one because you find it and you're done, because it's everywhere, right? So,
I got a thing on my cheek that I was like worried. I was looking in the mirror this morning. I was like, I don't remember this.
Yeah.
I got to go see I'm in my 40s. I got to get a dermatologist now.
Right. And so, again, it's not the worst of our problems. Sure. Melanoma is not the worst of our problems, but me as an individual, like I can say, okay, is there anything I can do to shift the risk, equation here? And do I wear it all the time? No, but do I just blindly say, to heck with it? Like I know that, UV, radiation and skin damage is bad for me, but who cares? Right. Yeah, I can do that. So again, that's another great, that's a personal freedom. Like I can choose to lower my risk or not. Right. I can choose to lower my risk or not by putting sunscreen on.
But it's the gray area that I, as a layperson, get stuck in, where I'm like, okay, I would like to lower my risk of skin cancer, melanoma. Okay, great. Mm-hmm. You want that. Sunscreen can help with that. Mm-hmm. But the wrong sunscreen increases my risk of illness in a different way. So then it's like, okay, what's the principle? Reducing risk is good here, but then if you apply that same principle to certain sunscreens, that's bad. So then the question becomes, which sunscreen? And then you're paying, $15 per bottle of sunscreen for this little spray-on thing that only lasts like 2 days, right? And then I'm like, okay, it's so expensive that I don't actually have the money to get the good stuff on a regular basis. So now do I roll the dice? Like I only put it on half the time? Or it's like, these are the problems where me as a person, it's like I get information from the scientific world. Sunscreen is good, skin cancer is bad. Mm-hmm. And even trying to parse that out, it's like, oh God, how do I figure this one out? Because it's not any sunscreen is good. Yeah. It's like certain sun, blah, blah, blah.
And really the biggest point in all of this is sunburns are bad.
Yeah. Okay, that's great.
Sunscreen is not the only thing, you can do, right? You have options, you have choices. But your point is well made that, despite our best, intent and efforts, we're not always right. We're not always right.
But I want to be right. Yeah. I want to get the Chatty G to tell me just how to go through the world, like how to make the right decisions. This is my anxiety.
Yeah. Take it, and we have the luxury of, we're talking in a country where we have just tremendous freedom and, and really overall an abundance. Take our most impoverished, population and match it with, the impoverished populations elsewhere. Like, we have choices, we have options, and that's a pretty great thing. Awesome. I think we're starting at a great place. I think right now there's a lot of people throwing their hands up in the air and say like, oh, this country's, going to pot, where sky is falling. Like, you know what, we're okay. We can work from this base. We can get better, I think we have to remember, as much as focusing on the problem, we become very problem focused. Media cycle, right? Right. We all want to talk about problems. We're not talking enough about what's right with America, what's good with America, what's good in the state of Idaho, right? We're talking about some of the issues we need to address, but, we're talking about we want to get to a better place.
It's the Yelp paradox, though. Yeah. I go to a restaurant's review, it's got 55-star reviews, but it's got 1 star, and I'm like, oh, what you want to read that? Yeah. Like, there was a fly.
Well, hold on, because going back to you still want to maintain that healthy skepticism, right?
Right.
You still want to know the full story, right?
Right.
As long as we're not diverting too much attention to that one thing. It's like, I talk about the ivermectin thing. Is like, what's that going to affect? Nothing. It's really not going to affect anything, but it could potentially open the door to worse. How about, ivermectin's okay over the counter? Why can't I get testosterone shots over the counter? Right. bro.
I think I'm the only person I know that doesn't do TRT. Like, and I'm
You and I both, and that's
yeah.
why I'm shrinking.
Yeah, I'm on the natch. I don't like no, all of my friends in jiu-jitsu, they're all just like they got patches, they got shots. I feel great, bro. I feel like you feel about 3 times stronger than you did last month too. It's like, I feel awesome.
Why can't that be over the counter? Ivermectin is. Why not? Testosterone's
so
natural. It's a natural product.
Oh my gosh. I know. I just try to get sleep. I try to get more than 6 hours of sleep and just roll the dice, hope everything's fine. Right. How much when we talk about science, there's a romantic aspect, or there's a romantic vision of, let's say, individual health during like the 1800s.
Yeah.
Right, where it's like, look, man, they ate things that they grew and they ate things that they killed. They also had terrible water. Like they had all these things. But from a dietary standpoint, people were like, yeah, man, they ate beef, they ate pork, they ate vegetables, dirty water. But, whatever. I think, or do you think that we're going through this wave of coming to terms with what in the middle of last century, we started to be able to do with science when it was like Crisco. Mm-hmm. We invented Crisco. We're like, oh, this is better. Like we essentially had, through science, we essentially developed all of these hammers, and then we invented nails where it's like, I invented this thing that doesn't have saturated fat. Mm-hmm. Let's make saturated fat bad. So then we marketed these things. Right. Like I remember for the first time having a Country Crock margarine, and I was like, this is lit. I was like, it spreads on perfectly. It tastes great. And then I come to find out, I was like, oh, you're going to die. Like, don't partially hydrogenated,
That's
not
good for us.
Right. So we had this wave through the 50s and 60s and 70s of, fat's bad, use this stuff. And then we had the sugar is good and let's go low fat, high sugar, carbs are good. We went through this like 50 years and then like Atkins was essentially this thing that came out of that where it's like, hey man, this doesn't really look like it's going well for you. And we don't know why, because that was a giant criticism of Atkins, where it's like, where's the research that says this is good? But people just recognize empirically, they're like, people are getting better results just eating eggs and bacon and, black coffee than eating the cereal. Like, why is that? And it's like, well, and so we have this, what I have experienced as a person, it's like, wait, it was like the overutilization and overbelief in the science that led to this problem. And even if you look in the nutrition world, it's like, who do you trust? And so I have this propensity to go back to, all right, man, is that a tomato? Did I grow that tomato? I grew that tomato. Right. Tomato's fine, right? Or like, that's the beef. Like, okay, I like the beef. This other thing, I don't even know what this is. Like,
but to a certain point, it was almost... really not that important, right? Because you weren't pulling out the food pyramid when you were deciding what you were going to have for lunch, right?
Well, I wasn't pulling out the food pyramid, but the food pyramid instructed what communities valued, what stores purchased, what was available for individuals. You didn't have the same kind of like, my wife gets chomps, those beef, meat sticks. The high quality meat stick was not like this great snack option back in the 90s because people were like, oh, meat's bad, fat's bad. Give your kids snacks, like just these BS snacks.
Yeah, but we always knew McDonald's was not great for you, right? But
sure, but Honey Nut Cheerios have the National Association of Health or Heart people, whatever, even though they're just all sugar and BS.
Yeah, I think that at the end of the day, I think most of us really know what's appropriate to be eating, and we eat the things we eat because we want to. Right?
Listen. My wife, when I met her, we were in college. Okay. And of course, when you're in college, you like do dumb things. And one night I was like, I really want French bread and barbecue sauce for dinner. So we go to the store and get Semi-Freddy's loaves. Oh, dude, it was so good. And we got like barbecue sauce. This is my claim to fame. We scoured the barbecue sauce aisle in the Safeway for like 10, 15 minutes. Looked at every single, it was like, how much sugar's in it? Because I was like, I want the sweetest barbecue sauce and the like best French. We found Sweet Baby Ray's barbecue sauce. It was low. It was bottom shelf at the time. And this was like 2005. Nobody had found Sweet Baby Ray's. And I was like, this has the most sugar per serving out of all of it. So we go home and we eat all of the French bread and we eat all of the barbecue sauce. And the whole time my wife is like, yeah, but it has no fat. Like, it's okay. And that was the thing. It's like, you could plow through a whole loaf of French bread. Now, did we really know at the time that's bad? No. So when you're like, hey, I think most people know it's good and bad. How? What's good or bad? Is it vegan? Is it paleo? Is it French bread? Is it bread only if you let it rise and double fermented? Like, what is right and wrong?
Yeah, I don't know, but I'll just, for me, like, if I'm putting on weight, you know what? I know it's because what I'm eating and what I'm not doing.
That's
right?
fair. That's fair.
It's not just magically, this fat isn't magically appearing on my body. Like, I know it's because I'm eating bad food and I'm not exercising, right? And that's what actually, going back to Make America Healthy Again, that's the basis of this proposal, really, is can we just restore things to a little bit of common sense? We shouldn't be putting a bunch of chemicals in our food. There's no reason for that, right?
Profit margins.
But really, do we really need to do that? I'm fine with that. But what I'm not fine with is throwing out things that we know work. In that mix. That's what I'm concerned about right now, is that because, we've become so divided in terms of our teams and our political ideologies, I don't want to see health be politicized.
Anymore.
At all. Out there. At all. I just think that's just, there's no place for that.
So the whole healthy fat movement, like the bodybuilding movement of, like people that are 300 pounds, and it's total politics, right? Because it was like, you can't say that somebody who's 400 pounds is unhealthy. You can't say somebody who's 350 pounds is not attractive. Like, you're a bad person if you do that. Yeah. It's like, what do you mean?
Yeah.
And that's straight politicization.
It's risk benefit again. It goes back to risk benefit. Like, you want to be a linebacker, then you got to put the weight on, but you're going to pay the price.
Bro, how many people that are 400 pounds are linebackers?
No, I know. But yes, come on. You're right. But again, we certainly don't want to normalize things that we know are not good.
Right. That's what I'm getting to. And there was this political movement to essentially say, like, everybody is beautiful.
Every body shape is healthy.
Everybody, forget the beautiful thing, but healthy. Yeah. People were attempting to redefine healthy. And obviously through medications, people are getting the rose without the thorn, right? You're getting like Ozempic is helping you have the appearance of a lifestyle. You have the appearance of not eating very much and working out without having the burden.
Yeah. Well, let's all hope that Ozempic and the other GLPs, that they work and they don't have problems. Because like we talked about, like in 10 years, we might find that Ozempic is the worst thing ever.
My God.
Right?
Right.
We don't know. It's way too early on that kind of experiment, right? We know the outcomes of 18 months of being on Ozempic or 2 years or whatever, but we know the long-term effects. But, looking back and saying, well, obesity is one of the biggest health crises we face in the United States and the world, really. If we had a drug like Ozempic that didn't have side effects, that would drastically bend the curve of, our economic expenditures in terms of GDP and healthcare. Huge benefits, but we don't know. It's the banana boat issue, right? Everyone says it's good for you. You're getting good results.
And an honest question. Do you think, I hear what you're saying, 100%. Let's make the assumption that people that are morbidly obese, that are reducing productivity, using tons of medical services on like 12 different medications, that is a result of one of two things: overconsumption or poor quality consumption. So you're like eating Doritos and other bad things, or you're eating excess and you have bad habits, right? So what I'm asking is, we could get the weight to come down theoretically with Ozempic, but do you think that would actually improve the cost of medical care for these people because their actual habits are so bad? Like, you're still going to be eating Doritos. You're still going to be consuming sugar. Maybe the weight came off, but your overall health will likely not be that much improved.
Right. Yeah. And exactly. That's definitely one of the questions that we haven't answered yet. And the kind of the third thing in there is, mental health is a huge component of it, right? Because a lot of our unhealthy eating comes down to mental health. And when I say mental health, I also want to say, like, let's get rid of the stigma around mental health. Everybody's got mental health issues. Everybody. We cope and deal in different ways. But we can't say, like, oh, I don't have any mental health issues. We need to be able to first address that piece, but and then I think we'll be able to get to the root of a lot of these problems like obesity. And again, we won't have to normalize, bad behaviors, because we understand that they're bad behaviors, but not because someone wants to make a bad behavior. They have some tendencies that they need help with.
You know what's interesting about, first off, I couldn't agree with you more. We need to help people understand that, like, mental health issues are everywhere. Like, I had no idea that I am manic, I'm depressive, I'm, borderline, all of these things, but I stave it off with clean living and incredibly difficult workouts. Yeah. I didn't know that I had those problems until I was restricted to my house. I couldn't do jujitsu anymore. I couldn't engage in meaningful community and relationships. And all of these mental health things piled onto me to the point where I was like, oh my God, I'm falling apart. It was just like, it exists in all of us. Right. If put into enough wrong positions, we will all fall into depression and anxiety and all of these terrible things. Yeah. And I have a dear friend. He's like, I'm a fat person that just has skinny person tendencies. Because he's like, if I see a tin of brownies, I'm going to eat the hell out of those brownies. Yeah. And he's like, but he also works out like a crazy person. Yeah. He's like, but I would be morbidly obese if I didn't counter all of that with all of this other stuff. Coping, and it's the same thing with mental health.
Yeah, absolutely. Absolutely. Yeah. I think, it was a little bit of a revelation, to me. A good way of looking at it is that, our brains are amazing. They allow us to do the most amazing things of all the living species, right? Our cognitive capacity allows us to solve problems, do things that's just, just mind-boggling. But, I listened to this gentleman, Mo Gaudat. I don't know if you've heard of him.
No.
Mo Gaudat was one time kind of the director of Google's kind of X, project, all their big projects. But his big take right now is that, the two biggest things we need to fix right now are our ability to find happiness in life. And interestingly, joined to that is artificial intelligence, because it has the potential to really cause some waves in the coming, future. But one of the things he says is that you have to realize that there's nothing wrong with our brains. It's the software it's running, and we can change that software. And I think that's where, we can start thinking about, okay, what are some of the solutions here? Like kids who have anxiety and depression right now, it's not their brains. Their brains are not the problem. It's the software they're running on it, the programs, the thoughts, that they're
the inputs, the systems they're put into.
Exactly. So we just need to tweak the software that's being executed, and we'll be able to make changes. So your friend, for example, who's pounding the brownies, right? Right? He's making adjustments to his software, saying, okay, I'm doing this, but on the back end, I'm also doing this to counteract and do some balancing here. So.
I couldn't agree more. The articulation that there's some, like, our kids are somehow different now. Yeah. It's like that we're fundamentally, it's like, no, we're not. Or that, hey, check this out. This is a wild thing. People are not different. To your point, the software we're plugged into, this neighborhood that we're sitting in right now has a Facebook page, okay? And it's a private Facebook page for homeowners or people that happen to be renting, people living here, okay? And it was originally intended for, like, hey, here's my sourdough starter, or hey, we're setting up a farm stand.
I got some extra zucchini.
Got some extra zucchini. Yeah. Like, it was meant to be like, hey, I just got this membership at this car dealer, and it's awesome. Like, in case anybody else wants to, like, whatever, right? Yeah. Just neighborly things.
A community.
And it did exactly what every other social media platform does, and it dissolved into just bickering, quarreling, people doxing each other, complaints nonstop. And the guy who runs it recently shut it off. And he put out this last minute. He's like, I'm turning off posting. This was originally intended for whatever, like sourdough, right? And he's like, and it has become this other thing. What I find very interesting about that is now, what will people think of the community if they're not exposed to constant complaints or constant criticisms? And it's like, the community hasn't changed. The people haven't changed. What you changed is the way the people interact. If somebody wants to complain about something, one, you have to be sitting right in front of them now, which means the people everybody knows the people that are always on there complaining, right? Well, are you actually friends with that person in real life? Do you see them on a regular basis? Because if you don't see them, that person all of a sudden like effectively got muted, right? Or the people that always come on, like have a little, like make a little comment, just like drop a little cherry bomb. All of those things, it's the same community, but we're going to experience it differently now because we changed up the software. And I'm actually really optimistic. I'm like, this is a great place. There are good people here. We've upregulated poor tendencies and given a microphone to people that we wouldn't interact with anyway. Because if you have a super negative person in your life, you're probably not hanging out with them. But if you're exposed to them constantly, you're like, I don't like seeing these comments, but I can't stop seeing these. Like, it's got to be different.
Yeah. It's the loudest voice phenomenon, right? That was not your community, but the loudest voices made it seem like that was the community.
Yes. Yeah. So again, to your point, I think it's going to be very interesting to see how this works out. And these are with adults, right? If you do the same thing with kids, and we find out all the time, all the terrible situations our children are in with tech at school and tech at home. And again, go outside and dig a hole. It's like, get on the ATV and hit a jump.
Exactly. Find something productive.
Parker, listen, I know it's a working day. I have so enjoyed chatting with you, man. I would love to have you come back and keep the conversation going about getting our medical industry focused again on medicine, not focused on politics, not focused on business decisions, but helping me understand, like, okay, what are other areas where you can see business or politics or just something other than medicine taking over the medical community? Because we got to get back to medicine, right? Like, we have to get back to having professionals that want to engage in it and best practices and freedom of choice, right? Like, whatever you want to do, but like, let's have medicine be about medicine.
100%. And again, like, I'm committed to this state. I want to see this state, not be number 50, right? In some of these healthcare indicators. I want to see us at the top, right? And so that's, and I think we all do. It's just finding the way.
Yeah. Listen, we don't have to be number one. Can you just get me to like the 30s? Like, we're 50th. Right. We just hit 38. Yes. If we hit 38, I would just, it would be exciting.
Agreed.
Thank you for coming on, sir. We'll do it again.
Absolutely. Thanks, Matt.